Hello, my name is Erik Munson. I am Associate Professor of Medical Laboratory Science at Marquette University in Milwaukee, Wisconsin. I'm privileged to discuss the sexually transmitted infection organism, Mycoplasma genitalium. STI surveillance, ongoing in the United States from a variety of institutions, both local, regional, and national. Data that were published by the Centers for Disease Control and Prevention in around 2021 has updated STI prevalence or incidence statistics, and I'd like to highlight a couple of those. The overall message from the CDC is that STIs, sexually transmitted infections, remain at a level that's way too high, even in the face of a pandemic, and I'll talk about that a little bit later. But with respect to two agents in particular, Neisseria gonorrhoeae and Treponema pallidum, which are the etiologies of gonorrhea and syphilis respectively, those incidence rates have taken a tremendous jump in the 4 years from 2017 through 2021. So in 2021, around 700,000 cases of gonorrhea were reportable. And remember, gonorrhea is a reportable illness at local and public health levels. Syphilis cases have risen by almost 70% since 2017, to the tune of about 175,000 cases reported in calendar year 2021. Particularly worrisome within syphilis is what's known as congenital syphilis, or syphilis among newborns. And 3,000 such cases were reported to the CDC or local public health in year 2021, which is nearly a 200% increase from 2017. So anyone who engages in unprotected sex could get an STI or a sexually transmitted infection, but certain demographics appear to be at greater risk. And these include young folks getting into the high schools and college-age population, age 15 to 24, gay and bisexual men, pregnant people, that is CDC language, as well as racial and ethnic minority groups, again, CDC language. One complication from sexually transmitted infection in females is cervicitis. And the diagnostic criteria for cervicitis is twofold. Number one, a purulent or mucopurulent endocervical discharge visible in the endocervical canal. And that is shown by the digital image that you see toward the right of your screen, the purulence or pus production in the cervical region. That can differ from, say, the strawberry cervix presentation that you might see with Trichomonas vaginalis. But again, that mucopurulent demonstration is not specific for Mycoplasma genitalium, nor is it specific for any particular STI. And secondly, among the criteria are signs of inflammation, such as sustained endocervical bleeding when the cervical os is induced by a gentle passage of a cotton swab. So in other words, if a cotton swab touches the cervical os and visible bleeding is observed, that can be diagnostic or a clinical diagnosis of cervicitis. Now, cervicitis, especially in women, is frequently asymptomatic. So women oftentimes do not demonstrate symptoms related to a cervical infection. Now, taking cervicitis one step further is the entity of persistent or recurring cervicitis. And the definition of this is cervicitis that persists after treatment. And it's important to note that most persistent or recurring cases of cervicitis are not caused by reinfection with Chlamydia trachomatis or Neisseria gonorrhoeae. Now, going back a step or two, cervicitis has been known to be caused by Chlamydia, Neisseria gonorrhoeae, Trichomonas vaginalis, as I alluded to before, herpes simplex 2 virus, and Amgen. But with respect to recurrent or persistent cervicitis, generally chlamydia and gonorrhea are not agents of that, and therefore bacterial agents such as Mycoplasma genitalium needs to be entertained with respect to persistent or recurrent cervicitis. Another clinical condition of note in women is pelvic inflammatory disease. Now, pelvic inflammatory disease can be difficult to diagnose because symptoms may range from mild to severe, or women may actually exhibit nonspecific symptoms. So the diagnostic criteria for PID, pelvic inflammatory disease, is one of 3 clinical criteria during pelvic examination. These would include cervical motion tenderness, uterine tenderness, or adnaxal tenderness. So 2 bacterial agents are typically causative agents of pelvic inflammatory disease. That is Chlamydia trachomatis and Neisseria gonorrhoeae. And again, PID can be prevented upon initial or primary diagnosis of Chlamydia trachomatis and Neisseria gonorrhoeae from, say, a cervical specimen or an endocervical specimen. So pelvic inflammatory disease is a complication of initial chlamydia or gonorrhea infection. However, recent data have associated the pathogens Trichomonas vaginalis as well as MGen with potential pelvic inflammatory disease. And some significant data from that include the fact that up to 22% of women with pelvic inflammatory disease actually have a documented M. genitalium infection. So because not all cases of pelvic inflammatory disease have a Neisseria or chlamydia etiology, MGen needs to be considered with respect to conditions such as that. And frankly, it needs to be considered with respect to other morbidity related to sexually transmitted infection. So MGen is a prevalent, often misdiagnosed sexually transmitted infection agent. It was first characterized in the early 1980s, I believe in David Taylor Robinson's laboratory in England, first identified within the context of male non-gonococcal urethritis. So I'm going to use that term to define cases of male urethritis that are not caused by Neisseria gonorrhoeae infection. And later that definition has been expanded to urethritis not caused by Neisseria gonorrhoeae nor Chlamydia trachomatis. The organism MGen does live on the epithelial cells of urinary and genital tract. It causes significant morbidity in men, and indeed, it is a sexually transmitted infection. So the big topic here of this slide is, why are we only hearing about this now? And the quickie answer to that question is there has been a significant gap in our knowledge. It's not for a lack of trying, it's a gap in knowledge because it's taken a long time for very good diagnostic testing modalities to come about for MGen. And you know, this has been true for other STI agents such as chlamydia and trichomonas, for example. Gaps have existed in those paradigms, leading to suboptimal testing methods for a long period of time. But the good news is now that better testing methods have come about, we have learned a lot more about these organisms, including MGen. So let's date back to the early 1970s. Clinicians were learning that non-gonococcal urethritis can be actually treated with antibiotics in the face of a negative gram stain or a negative culture. So this means that back in the old days with Neisseria gonorrhoeae diagnosis in males, that could be diagnosed by simple gram stain, where you saw gram-negative intracellular diplococci inside a neutrophil. So that alone could have been a diagnosis for gonorrhea in men. So clinicians were finding urethritis that were negative for culture, negative for gram stain, treated with antibiotics, and resolved with antibiotics, which led them to believe that perhaps there were other bacteria that were causing urethritis that were not Neisseria gonorrhoeae. And in fact, in my earlier days as a laboratory director, I had a clinician come up to me after we released molecular trichomonas and molecular gonorrhoeae and molecular chlamydia results, some of those being off-label testing, and he says, I have patients with urethritis who are negative by all three of your tests. I think this is Mycoplasma genitalium. Can you test for it? So that's one of the first indicators in my mind that brought to significance the potential effect of this infection. So going back to the 1980s, Mycoplasma genitalium was able to be cultured mostly in research laboratory settings. The caveat to that, as we will get to in a little bit, is that culture for Mycoplasma genitalium does take a long time to yield a positive result. So therein lies that gap that I was alluding to. We were going for years and decades practically without a great test for MGen. This drew to a close around the middle 2010s, and indeed in 2015, CDC in their STI treatment guidelines actually recognized at that time Mycoplasma genitalium as an emerging infection and actually recommended nucleic acid amplification testing for the laboratory diagnosis of MGen, probably due to the fact that culture, while successful in many situations, was number one, not readily available, and number two, had a rather long turnaround time, if indeed positive. Then we fast forward to about 2019, where the US Food and Drug Administration actually cleared the first nucleic acid amplification test for Mycoplasma genitalium, And 2 years after that, in 2021, when the most recent STI treatment guidelines came out, CDC actually recommended testing specific populations for MGen, perhaps in part because there is now a valid test or a reasonable test out there for most laboratories to implement into their practice. So indeed, detection of MGen requires nucleic acid amplification testing. So this is piggybacking off of that CDC recommendation made in the 2021 guidelines. We will talk in a few slides about how the clinical presentation of M. genitalium infection can be similar to that in STIs, right? So there's not one specific diagnostic or clinical criterion that leads a clinician to highly suspect MGen. There's so much overlap that you really need a solid test in order to definitively identify MGen. As I alluded to before, MGen cannot be seen on gram stain or microscopy. This is related to the fact that MGen does not have a cell wall. So it comes from the class of bacteria called mollicutes. This would include your mycoplasmas and your rheoplasmas. And one of the unifying characteristics of those organisms is that they have cell membrane only. They have a tri-layered cell membrane, but no cell wall, which means two things. Number one, you can't gram stain them, you can't observe them by microscopy. And more important for the clinicians, number two, you lose a whole battery of antibiotics, such as your beta-lactams and your glycopeptides and several others that would be cell wall active. So you have to rely on alternatives such as fluoroquinolones, macrolides, and tetracycline-like agents. So that's something also to consider for MGen. As I mentioned before, if you look at a textbook, it often says that it takes 3 weeks to cultivate Mycoplasma genitalium, but in the experience of others, it may take longer. So culture is really not feasible for the quick laboratory diagnosis of a patient with MGen infection, and ergo, the nucleic acid amplification test is indeed the recommended method of detection. So let's spend a few slides talking about clinical presentation of M. genitalium infection. I already alluded to the fact that it could overlap with other STI agents. This slide indeed shows that M. genitalium, which is in the far right column, can have clinical presentation or symptoms that can overlap conditions such as gonorrhea, chlamydia, yeast infection, and to an extent trichomoniasis or infection by Trichomonas vaginalis. So a discharge, which is beyond what's normally seen in women, can be exhibited by M. genitalium infection, as well as vaginal irritation and pain during intercourse. Now, bacterial vaginosis would be similar to that in some respects, but bacterial vaginosis along with trichomoniasis would also exhibit that fishy or vaginal type of odor, and that would differentiate from M. genitalium. But still, there's so much overlap that you really need a solid diagnostic test to really identify M. genitalium infection. So again, with respect to females, primary M. genitalium infection can lead to significant health consequences, and we've alluded to a couple of these already. So M. genitalium in some studies has been detected in about 10 to 30% of women with clinical cervicitis. Individuals under the age of 34 are the most likely to be affected with MGen. And you know, that's sort of the pregnancy population perhaps. So this could be an issue in the OB/GYN community, perhaps. We already mentioned that there's no link so far between M. genitalium and pelvic inflammatory disease, but there are associations that have been made. And in fact, up to about 1/4 of individuals with PID have documented MGen infection. And there is a meta-analysis published in, I believe, 2015 that made some associations, at least from a meta-analysis standpoint, of M. genitalium infection with conditions such as cervicitis, PID, and now we're getting into infertility, and there's the adverse pregnancy outcomes once again. So again, pregnant women or pregnant people, as the CDC mentions, could be a potential demographic that could be at risk for M. genitalium infection. Now don't forget about the men, and of course MGen was first characterized in males anyway in the early 1980s, but additional clinical data have emanated from studies of males with respect to MGen. So first of all, it's important to remember that male urethritis with MGen tends to be more symptomatic than cervicitis in women with MGen. So males with urethritis caused by MGen tend to be more symptomatic, and they may actually seek medical care, right? Men hate going to the doctor. My dad hated going to the doctor. I hated going to the doctor. But if you're showing signs and symptoms of an STI, that's a pretty good way for a male to seek medical care. And indeed, that's true with MGen infection. So one study actually showed that almost 3/4 of MGen positive men show signs and symptoms of urethritis. Now, with respect to persistent or recurrent urethritis, MGen has been demonstrated to be responsible for about 40% of those cases. And then finally, if you look at the bottom bullet point, in men with acute non-gonococcal urethritis, MGen is the culprit in about 25% of those men. And if you expand the definition of urethritis to include chlamydia, the non-chlamydia, non-gonococcal urethritis, MGen is responsible for over 1/3 of those cases. All right, let's get a little bit more into the prevalence of MGen. And again, it's my opinion that these prevalence data are enhanced with better diagnostic methods. So let's see what these better improved laboratory diagnostics has to our overall understanding of MGen infection. So some early work, I believe this was done in Europe, have demonstrated overall prevalence in the general population for MGen anywhere from 1% to 3%. Now, this is considered a low-risk population, and if you look toward the bottom of the slide, there's a couple of bullet points that sort of define a low-risk population for STI infection. In other words, a general population, maybe patients attending a fertility clinic, or in general, patients not attending an STI clinic. When you stratify prevalence studies on the basis of high-risk patients, you come up with the data that you see in the middle. So in females in high-risk populations, prevalence studies have estimated around a 7 to 14% prevalence, whereas in certain high-risk populations, anywhere from a 10 to 41% population. And the high risk could include patients attending an STI clinic, patients presenting to family planning clinics for termination of pregnancy, symptomatic individuals, commercial sex workers. When I directed a laboratory prior to my moving on to Marquette, our prevalence rates in women were higher than those that are demonstrated on the left-hand column. So please note that prevalence rates may vary as a function of geographic location. All right, let's get to a couple of slides on guidelines. These are reflective of the 2021 CDC STI treatment guidelines that came out, and everybody was very excited about this. Before I mention anything on this slide, what's noteworthy about the 2021 guidelines is that MGen has its own separate section within the CDC guidelines. Rather than just a passing or an emerging thought, it actually has a dedicated section to epidemiology, prevalence, diagnostic testing, as well as treatment recommendations. So let's go through a couple of these on this slide. With respect to females, testing is recommended for women with recurrent cervicitis and should be considered in women with PID. Remember what we said about PID, chlamydia and gonorrhea have the link with pelvic inflammatory disease. Currently, MGen is associated with pelvic inflammatory disease, and some studies have shown that 25% of women with pelvic inflammatory disease have documented MGen infection. With respect to males, MGen testing is recommended for males with recurrent non-gonococcal urethritis. In recent years, the paradigm has come up with respect to mycoplasma testing in the context of sexually transmitted infection in the further context of what we like to call syndromic panels. Syndromic panels are those that incorporate multiple analytes when looking for a specific type of disease in a patient. So you could have GI panels, respiratory panels, and sometimes the topic of mycoplasmas come up in STI syndromic panels. So according to the CDC, data are rather inconsistent regarding Mycoplasma hominis and ureaplasma species as etiologies of urethritis. And furthermore, a role for ureaplasma parvum and ureaplasma urolithecum has not been associated in female cervicitis. Or they're adding further support to the recommendation that ureaplasma parvum, ureaplasma urolithecum, and Mycoplasma hominis both not be included in syndromic panels or be used for routine screening of cervicitis and urethritis. All right, let's get into the treatment of Mycoplasma genitalium infection or MGen infection as per the most recent 2021 CDC guidelines. So treatment of this organism was indeed addressed in the CDC guidelines, but it was additionally addressed in some of those antibiotic resistance trending documents that are published on a semi-annual basis by the CDC. Now, as you know, these sort of document like the top 10 nastier infections or top 12 nastier infections, organisms we should be looking out from either a treatment perspective or a surveillance perspective. And in the most recent antibiotic-resistant threats, MGen was included within this document in sort of a category that people call the watch list. And the watch list refers to organisms that could have resistance that furthermore could be seen with more frequency in the future. So MGen was included on that list, especially with respect to macrolide-resistant MGen. So macrolides are drugs that are bacteriostatic drugs. They include agents such as erythromycin, clarithromycin, azithromycin. The agent of the macrolides that's most pertinent to the treatment of M. genitalium infection is azithromycin. So in the position statement of antibiotic-resistant threats, they quote that M. genitalium bacteria are sexually transmitted and can cause urethritis, can cause cervicitis in women. They go on to note that few antibiotics are actually available to treat M. genitalium infections. And we sort of alluded to that earlier in saying that MGen does not have a cell wall, so you lose several classes of antibiotics that could be available to treat those. So resistance to azithromycin, which has been recommended in the past for treatment, is high across the globe. Now, depending where you are on the globe, these rates could vary, but data from the United States have shown that MGen macrolide resistance rate or azithromycin resistance rates have approached 50% and perhaps even higher than 50%. So yes, this probably is noteworthy or worthy for the watch list per the CDC. So treatment guidelines that are now proposed or now published by the CDC, I should say, are essentially based on whether or not a clinician has access to a laboratory that has access to resistance testing. So these treatment regimens are predicated on resistant MGen, macrolide resistant MGen, or non-macrolide resistant MGen. So if you have testing methods available and if you're macrolide susceptible, the first line agent is doxycycline. That's 100 milligrams orally twice a day for 7 days. And the thought in the literature is that initial doxycycline treatment has been shown to reduce initial MGen burden within the patient. So it's sort of a first line organism reduction type of therapy. But after 7 days, this has to be followed by a macrolide. If again the testing shows it's macrolide susceptible, then you would follow it up with azithromycin at a 1 gram initial dose, followed by 500 milligrams orally for an additional 3 days for a grand total of 2.5 grams of azithromycin. Now, if you have testing available and your primary MGen test is shown to be macrolide resistant, then you would follow with the traditional or the first line doxycycline therapy, 100 milligrams twice a day for 7 days, but that would be followed not by azithromycin, but by moxifloxacin, one of the fluoroquinolones. That would be administered 400 grams orally for 7 days. So a grand total of 2 weeks of therapy for macrolide resistant MGen. Now, if your testing laboratory does not have MGen resistance testing available to the provider, then you essentially follow the paradigm of macrolide resistant MGen. So you're taking a very conservative approach in that situation. So now that we've covered prevalence, some clinical presentation, which again can overlap, let's talk about means of detection of MGen. And again, we mentioned, especially in the context of clinical presentation, the MGen clinical presentation can overlap so many other STI agents that it truly is important to nail down a laboratory diagnosis by way of properly sensitive and properly specific nucleic acid amplification testing for MGen. So here are some data published from Sweden that showed MGen DNA loads in first void urine. So These were essentially individuals positive for MGen from first void urine specimens, and they further went on to quantitate the DNA load in those individuals. And they compared DNA loads of MGen compared to DNA loads in Chlamydia trachomatis. And although the error bars overlap to an extent, the median bacterial load for chlamydia infection was 42-fold higher than that of MGen. And again, these are DNA assays suggesting that MGen may have a relatively lower DNA burden within the primary clinical specimen, meaning perhaps that there may be some limitations to performing DNA-based nucleic acid amplification testing looking for MGen in primary clinical specimens. One alternative to that is RNA amplification. There are multiple copies of ribosomal RNA per Mycoplasma genitalium organism. That's been borne out in the literature. What's been further borne out in the literature is that an RNA-based amplification test from MGen detects up to 40% of patients that were missed by a DNA-based amplification test. Now, this is not a paradigm specific to Mycoplasma genitalium. Other STI agents, such as Chlamydia trachomatis, Trichomonas vaginalis, and even hepatitis C in a clinical sense, have had similar data published in the literature, in that RNA amplification is more sensitive than DNA-based amplification. So here are the specific data I was alluding to on the previous slide, that 40% increased detection rate. The data on the left is a French study of combined males and females, and the light blue bar is an RNA amplification assay showing near 100% sensitivity, whereas the dark blue bar is a DNA-based amplification test, which shows decreased analytical sensitivity. The study on the right is a Scandinavian study encompassing both genders. The bars are a little bit different on this one. The DNA amplification assay is the gray bar. I'll get to the dark blue bar in a minute. And the light blue bar is your basic screening RNA amplification assay. And again, the data are demonstrating a 35 to 40% increase in analytical sensitivity with the RNA amplification method. Now, the dark blue bar in the NAME study, or the Scandinavian study, is an important feature, at least in my opinion, and that was utilization of what's called an alternative target RNA amplification assay on the same set of specimens. So in the literature, it's sometimes contended that RNA amplification discordant results that tend to be more sensitive by the RNA amplification assay could be the result of a false positive result or a lack of specificity. But the value of using an alternative target RNA amplification assay is using the same mode of amplification, but using a different target within the MGen. And when those studies were done by the European group, you saw essentially the same level of analytical sensitivity, again suggesting that the primary RNA amplification assay is a truly sensitive and specific assay for molecular detection of MGen. So in summary, MGen testing is recommended for women with recurrent cervicitis, males for recurrent urethritis, as well as women with clinical evidence of pelvic inflammatory disease. Remember, the links are with chlamydia and gonorrhea. Associations to date are made with MGen. And of course, these require further clinical studies in the literature. Testing for the correct infection, yielding the right therapy is critical. This again relates to the fact that clinical presentation of many STI agents can overlap, and therefore accurate, i.e. sensitive and specific testing is absolutely necessary to identify the true etiology of disease. In the 2021 guidelines, remember that MGen has been given their own section of relevance or importance, and indeed, nucleic acid amplification testing is now the CDC recommended method for laboratory detection of MGen. In the last couple of slides, I discussed data that showed that the analytical sensitivity of RNA-based amplification is improved or enhanced over that of DNA amplification. And is not just true with MGen, but has been demonstrated in the literature for other agents of STI. Thank you very much for your attendance and participation.